Hi, my name is Maureen Walton, and I'm a professor in the Department of Psychiatry. I'm happy to be here today to talk about opioid misuse and this important problem among adolescents and emerging adults. By the end of this lecture, I hope that you are able to identify rates of prescription opioid misuse and association with injury, as well as understand risk and promotive factors for opioid misuse, describe promising interventions, and recognize future directions in this topic. This graph shows substance use by age group from data collected from the National Survey on Drug Use and Health. And you'll see here the percentage of people self-reporting use of these various substances. Importantly, you can see that alcohol is the most commonly used substance among all age groups, followed by tobacco and marijuana use, with opioid misuse being the second most common illicit substance used among all ages. This slide also shows that substances are initiated in adolescence, which is shown in the light blue bars, ages 12 to 17. And some people are surprised by the fact that substance use peaks among emerging adults, ages 18 to 25, with adults ages 26 and older often reporting less prevalence than among that emerging adult age. You can see here that about 3% of adolescents and 8% of emerging adults report opioid misuse. And by opioid misuse, what this is determined in the literature to mean is a combination of things. First of all, it means using an opioid without a prescription, so using someone else's prescription. It also includes, however, using your own prescription, either more than was prescribed for reasons other than prescribed, in larger amounts, etc. Opioid misuse is associated with leading causes of death. This slide shows in the U.S. the leading causes of death in 2017. And the light blue on the top is the leading cause of death, which is unintentional injury. And you can see that's for ages up to ages 44. Unintentional injury includes things like motor vehicle crash as well as overdose. The second leading cause of death for adolescent and emerging adults is shown in green there, and that's suicide. And the third leading cause of death among this age group is homicide, shown in red. If we further pull apart unintentional injuries, you can see in this slide in the blue that motor vehicle traffic crashes are the leading cause of death for ages 15 to 24. However, at 25 years of age, as well as up to 64 years of age, overdose is now the leading cause of death. The sociological model is a useful framework that can be applied to opioid misuse and other is now the leading cause of death. Now the leading cause of death. The sociological model is a useful framework that can be applied to opioid misuse in order to understand risk and protective factors. The CDC has used this model across a variety of injury-related topics. In terms of opioids, what you can see here is that there's several individual factors that are associated with use. Older age, certain motives, ACEs, which include adverse childhood experiences that are typically negative, such as child maltreatment, mental health factors such as anxiety and depression, substance use, and delinquency all increase the risk for opioid misuse. On the other hand, protective factors are things such as religiosity and academic factors, including grades and school involvement. Next, social factors are important, and these are influence from peers and parents. Obviously, attitudes towards opioids, as well as opioid misuse among your social support systems and friends. Use this model across a variety of injury-related topics. In terms of opioids, what you can see here is that there's several individual factors that are associated with use. Older age, certain motives, ACEs, which include adverse childhood experiences that are typically negative, such as child maltreatment, mental health factors such as anxiety and depression, substance use, and delinquency all increase the risk for opioid misuse. On the other hand, protective factors are things such as religiosity and academic factors, including grades and school involvement. Next, social factors are important, and these are influence from peers and parents. Obviously, attitudes towards opioids, as well as opioid misuse among your social support systems and friends, is an important factor impacting opioid misuse. Sports involvement is a little bit tricky, and it has mixed influence on opioid misuse. And in fact, sports that are high-impact sports actually might increase the risk of opioid misuse, potentially due to their association with injury and early exposure to opioids. In terms of community factors, obviously availability and access are critically important in both initially using an opioid as well as increasing use to misuse. And finally, societal factors are important. These include things like prescribing laws and guidelines, PDMPs, which stands for Prescription Drug Monitoring Programs, which limit the number of pills, for example, you can get in a prescription. These are all factors that influence whether an opioid is misused or not. So what are some motives for prescription opioid misuse? There are many motives, and this slide is only showing two, for example. In these surveys, typically people check all that apply. And you can see in the blue bars are people that don't have a prescription for opioids. These are called non-medical misusers. This means I'm getting it from somewhere else. The orange bars show people that have a prescription, but are using it not as prescribed, differently than the doctor's telling them to use. Regardless of whether you have a prescription or not, you can see that the primary reason for misusing an opioid is pain, which is what opioids are usually prescribed for. The second most common reason, of course, is not what they're prescribed for, and that is to get high. So how are youth obtaining opioids without a prescription? You can see here, this is data from a survey of 12th graders, and what you see is that almost none of them are obtained from a dealer. Again, these are check all that apply questions, and over half of young people are saying that they got it for free from a friend or relative. The rest are also from diversion sources. Either they bought it from a friend or relative, or they're using their own leftover medications. Critically, prevention efforts are needed to reduce such diversion and decrease access. The CDC has 4 priority areas for prevention of opioid overdoses, which of course is a leading cause of death, as I showed you earlier. The first is to improve prescribing. This is things like the PDMPs, to reduce the number of pills, as well as other laws and policies. It is important to note, however, that it is critical that for people who do have pain, that they do have access to these really effective medications. However, we just want to reduce diversion to people who are not using those medications in an appropriate manner, such as the adolescent and emerging adults I'm talking about here today. Second is treatment of opioid use disorders. So the most effective treatment for opioid use disorders is medication-assisted treatment, and clearly we need to improve access to that. A third priority area is increasing access to naloxone, which is a medication that can reduce an overdose if given in time. Obviously, education and access to naloxone would be an important way to prevent or reduce overdose. Finally, the last area involves behavioral approaches. In order to prevent opioid use disorders, we must focus on both those with use and prevent escalation to misuse, as well as among misusers to prevent opioid use disorders. The director of the National Institute on Drug Abuse, Dr. Volkov, said that although reducing access and PDMPs and things like that are very, very important to reduce diversion, there's a clear need for behavioral interventions as well. If you think of interventions to address this opioid crisis among adolescent and emerging adults, if you think of the severity of use as a triangle, at the very tip of the triangle are people with an opioid use disorder, and clearly they would benefit from medication-assisted treatment. However, if you only focus on this tip, you're missing the broader part of the triangle, and those include people in yellow, shown here, that are opioid misusers who could benefit from interventions to decrease this misuse, as well as for those with prescription opioid use to prevent development of opioid misuse. There's no one best setting for efforts focusing on opioid prevention approaches. This slide shows that together, these approaches in multiple community settings are really what's needed to have true impact on this crisis. I'm going to talk about two today. One is healthcare settings, and the other is schools. School-based approaches are typically what we call universal prevention. They're given to all kids in schools, regardless of their risk. There are two programs that are evidence-based. One is the Strengthening Families program, and the other is the Life Skills Training program. Both of these are classroom-type sessions, with Strengthening Families also obviously involving the family. Although these interventions were designed to focus on substance use in general, research shows that they have secondary effects on reducing opioid misuse into the early 20s. And this is important because now that we have evidence that these programs work, research and practice should focus on implementation in this setting, namely schools. Healthcare-focused interventions are typically a little bit different. Instead of being given to everyone, it usually first involves identification of at-risk youth. And this is done by providing youth typically some sort of tablet where they can self-administer self-report questions. For example, there are evidence-based screens for opioid misuse include the NIDA Assist. Among users, though, to prevent development of misuse, you could also screen for other risk factors, and you can see 4 listed here that could be useful things to screen for, and those include depression, alcohol misuse, other drug use, and suicidality. So it could be in medical settings for users who have these additional risk factors, they may benefit as well from some sort of intervention. The evidence base for healthcare-focused early interventions is also emerging. What we find is that programs that are evidence-based to reduce substance use have secondary outcomes on reducing prescription opioid misuse. These include primary care-based studies as well as emergency department studies. Regardless of the focus, whether the focus of the intervention is on marijuana, substance use, alcohol, or directly on opioids, these 1 to 2 session-focused interventions also tend to decrease misuse, typically in the year following delivery. Therefore, an exciting area for future research is to test these interventions when implemented as part of clinical care delivery systems. In order to really combat this crisis, a lot of next steps are clearly needed. One potential next step is routine screening and interventions in healthcare settings. And the reason to potentially start in this setting is because these interventions address at-risk kids. Of course, primary care-focused interventions as well as emergency department in this area could be indicated. As I mentioned, school-based interventions would also be potentially useful with their universal focus given to all students in a school, for example, of a particular grade. Next, technology may provide a solution to help with scalability and sustainability of these approaches in various settings. Technology can be used potentially not only for screening in healthcare settings, but potentially to deliver the interventions as well. And future research is needed in this area. Another recommendation is that further research is needed examining longitudinal trajectories of opioid misuse. Most of the studies I mentioned earlier in that social ecological framework are cross-sectional studies showing associations at one point in time. What we really need is longitudinal studies because there's been a few studies that show that between a quarter and a third of youth who use opioids transition to misusing opioids within 1 year, which means 2/3 to 75% don't. What we really need to know is who is going to transition, when, and why. And so longitudinal research would really help us in this regard. Finally, obviously, we really need to optimize the delivery and timing of our interventions. And there are sort of two ways we could do this. One is with hybrid effectiveness implementation trials, which are really nice because they take research studies that are evidence-based and they move them into practice in a really compressed timeline than has typically occurred in the field. Next, there are interesting and innovative dismantling designs, such as the multi-phase optimization strategy. These approaches could be used to sort of take intervention approaches that have multiple elements and tease them apart and figure out what is the most important ingredients that were needed. We have a lot of work to do in this area to really combat the opioid crisis among adolescents and emerging adults. And working together with research and interventions, we can clearly address this problem together.